Good morning to my colleagues in North America and good afternoon to my colleagues in Europe. Let's see, okay. We have an esteemed panel of experts to help us manage these cases. I've tried to put on a wide variety of different cases so that hopefully it will illustrate some of the points that have been made during the course of the meeting. We have Lawrence Albier, we have Christian Wiesland, we have Hans Hammers, we have Lars Lund, we have Sylvie Negre, Lisa Pickering, and finally Tom Waddle. Just in the interest of full disclosure, I had bilateral cataract surgery 3 weeks ago, so I'm still having problems seeing. So if it looks like a blind man's trying to show you a CAT scan, it's only because he is. But with that, we will move on. I'm going to ask Dr. Lund to monitor the chat box, and if there are questions, if he could please bring them to my attention so that those questions could be addressed.
I'll do so.
All right, so how do I advance this? Let's see.
Click Start Presenting at the top there and click on that number 2 slide on the bottom.
Okay. All right, so I'm sure most of my panelists are familiar with the ground rules, but just to remind you, there are no tricks. The salient clinical information and radiographs are being shown to you to help you make clinical decisions. You can mention a clinical trial as a potential offering for a given patient, but we also want to hear what you would do in the absence of a clinical trial. Please tell us what you would do, not what you could do. We're interested in how you would practice, how you would see this patient in your practice and what you would offer that patient. Please explain the reasoning behind your recommendations. And above all else, please be brief. Brevity is a must. We have a lot of people to help today. So with those ground rules, let's go ahead and get started. So the first patient is a 65-year-old morbidly obese white female who presents with gross hematuria. Her BMI is 50. She has a CT scan of the abdomen that shows a locally advanced tumor involving the right kidney. She has no evidence of any metastatic disease. Her CT scan of the chest is negative. She has some anemia, but all of her other laboratory studies are within normal limits. And you can see her CT scan right here. You can see that she doesn't shy away from meals. And she has a locally advanced tumor involving her right kidney that extends centrally into the renal sinus. So I guess I'm going to talk to one of my surgeons first, Dr. Wiesland. What do you recommend for this patient?
I had some sort of difficulty with, there it comes. With that, I would have started with, if I had the whole CT scan, I would have seen if I should do a nephrectomy or a partial nephrectomy, radical or a partial nephrectomy.
Okay, I tried to show you the salient features. From my perspective, I don't think this is amenable to partial nephrectomy based on how centrally it goes into the kidney. So
no, I agree.
So let's just agree that we would. Let's just agree we would do a radical nephrectomy. My question to Dr. Lund would be, how would you approach this? Would you approach it laparoscopically? Would you do it open? Would you do a lymph node dissection? How would you approach it?
I think there's no actual lymph node in that picture I see here, so we'll go for a robotic nephrectomy, I think so.
Okay. Does anyone disagree with that approach?
We could have done it just plain pure laparoscopically as well.
Okay. And would you do a lymph node dissection or no?
No, not the lymph node dissection here.
Okay. So we actually took her for a flank approach nephrectomy, which we did, and she had an unrecognized level 1 tumor thrombus, which we resected. And her pathology revealed a T3A N0 M0 clear cell renal cell carcinoma with 20% sarcomatoid and 70% rhabdoid features. Thankfully, all of her surgical margins were negative. So my question to the panel is there any role for adjuvant therapy in this setting? And if so, what would you recommend? I guess I'll throw it out to Laurence. What do you think?
Okay, so there's no adjuvant therapy available in Europe. I would not offer sunitinib even if it was available. We do know that there are pending results with immune checkpoint inhibitors. So if I can enroll the patient in a trial, I will do so. Otherwise, I will not offer adjuvant therapy. We're waiting for the results.
Okay. Dr. Negria, do you agree with that?
Oh, yes, sure. We have no routine adjuvant therapy to propose, so I would like to include this patient to our clinical trial for adjuvant immunotherapy, sure.
Okay, does anyone on the panel disagree with that approach?
No,
I just have a comment. I think I will go back and have a look at the CT scan again to see where there is bone mets and be sure of that. Because the pathology is rather aggressive, I would also perform a CT scan of the brain.
Okay, that sounds reasonable.
We have had a couple of these patients. They can really metastasize quite quickly. So that I would do a very, very rapid control scan of the patient very soon.
Okay,
after.
so the patient comes back after 6 weeks. With repeat imaging. She has a hemoglobin of 8.8, an alkaline phosphatase elevated at 200, an LDH elevated at 987. All of her other laboratory studies are within normal limits. We do get an MRI of the brain, and we also get a bone scan, both of which are negative. And quite honestly, she feels great. She's recovered nicely from surgery, and she really has no complaints. So here's a look at her imaging. Unfortunately, her imaging doesn't match her presentation. You can see that she's got some mediastinal lymphadenopathy. She's got multifocal bilateral liver metastases. She's got a massive recurrence of tumor in the retroperitoneum involving the right psoas muscle with involvement of the retroperitoneal lymph nodes as well. Oops, sorry. Back to this one. So looks like she's having, as you all predicted, rapid progression after her surgery with metastatic disease to the liver, to the retroperitoneum, as well as to the mediastinum. Dr. Pickering, in this setting, what would you recommend to this patient?
Well, first of all, I'd be saying to my surgical colleagues that you were quite right about your level of concern about the histology, because she has recurred very rapidly. It's a nasty, aggressive, widespread recurrence, and she's anemic. I know she was anemic preoperatively also, but she's more anemic now. So not knowing, I forget, I'm sorry about all of her other labs, but she certainly has at least 2 adverse risk factors, being anemic and having a recurrence considerably less than a year post-nephrectomy. So she has at least 2 adverse risk factors. She may have had a third, and if she did, I missed it. So we're looking at somebody with either intermediate or poor risk metastatic renal carcinoma here. So I know she's morbidly obese. She was clearly fit enough to have surgery. You've told me that she's made a good recovery. So I take it from that her performance status is appropriate and adequate for systemic therapy. So I'm going to want to start early systemic therapy. With this aggressive histology, sometimes thoughts turn to ipilimumab and nivolumab, but actually I think I favor VEGF-TKI IO combination here because of I want to try and get a rapid recurrence. She has hematuria, and I'm worried about that. If her kidney was in situ, I'd be asking you guys if you could remove it for us, but her kidney's not in situ. So I'm a bit worried about the cause of the hematuria, and I would certainly be talking to my surgical colleagues about that. But in terms of systemic therapy, I'm thinking IO-TKI combination here. I work in England. We only have one option. It's axitinib avelumab. It's actually my least preferred of the IO-TKI combinations, but that's all I would have available to do.
And just as a point of reference, the hematuria was before she had her nephrectomy. The hematuria is resolved, so that's no longer an issue.
Oh, sorry, I missed that. Apologies, Chris.
Let's see, Dr. Waddle, what are your thoughts?
Yeah, so I mean, I agree with most of what Lisa said. I think the choice is really between IO-TKI or IO-IO. I have to say, I think in my practice, I would be more inclined towards combination IO therapy for a 65-year-old if there are no other contraindications and if she's not symptomatic from her current sites of disease, because although this is behaving aggressively, she doesn't send a rapid response from a symptomatic point of view, I think I'd like to give her the best shot at a long-term durable remission. So I think I would start with Ipi/Nivo. I may plan to scan slightly earlier than 4 cycles due to how quickly things have changed so far, and then sort of plan to abort and move to TKI if there is early rapid progression.
May I ask a question?
Yes.
If you biopsy these mets and you get a very high percentage of sarcomatoid features, or would it be a place for a more standard chemo in any other case?
If I answer that, I have to tell you my thoughts quickly. If I got a lot of sarcomatoid, that would actually push me towards IO with Ipi/Nivo rather than cytotoxic chemotherapy.
And I think the nephrectomy in this case was high sarcomatoid percentage. So yeah, I think there aren't patients in my practice currently that I'm using cytotoxic chemo in this sort of situation. It's still IO or IO-TKI if fit.
So that brings up 2 issues, though. So in this setting where the patient had her nephrectomy, we have the pathology from the nephrectomy specimen, how many of the medical oncologists would recommend biopsying metastatic lesions to get an understanding of their makeup?
So I would not perform biopsy given the time frame of the relapse. I would go for IO in this patient. We would recommend biopsy if the relapse had occurred after at least 2 years, which is not the case in this patient.
I think the worry would be that biopsy in this patient is an unnecessary delay, and you may just lose further ground whilst undertaking the biopsy and awaiting results. And I don't think we're in any doubt about what the biopsy is going to suggest.
I totally agree with Laurence and Dr. Waddle. This very aggressive disease, early recurrence, there's no doubt what we are dealing with. It behaves like sarcomatoid rhabdoid. The response to IO in this case is outstanding. The numbers really are 60% response rates, 20% CRs almost. So the efficacy is the same, if you will, even in the short term. Efficacy data very similar to TKI/IO, but I do think the long-term durability response is probably going to be better. I also agree with early restaging. I typically would get a scan 6 to 8 weeks in, and if there's overt disease progression, I would probably add, quite frankly, a TKI to the mix, try to continue with the immunotherapy, add a TKI, and then go from there.
Okay, so doesn't look like we have complete agreement. Some said IO-TKI, some said IO-IO, but I think in general, immunotherapy is probably in this patient's future for systemic therapy. Any other last comments?
Yes, I'm concerned a little bit by the rhabdoid component because in my experience, it's quite different from sarcomatoid. And because sarcomatoid tumors are more immunogenic tumors, and on the contrary, the rhabdoid component is more non-differentiated and poorly antigenic. So I have a couple of patients who did not respond at all to immunotherapy and have a benefit from TKI. So to me, this specific histology could favor the choice of TKI-IO versus double IO.
There's some small data sets from the Dana-Farber. There is an initial impression that maybe rhabdoid behaves somewhat similar to sarcomatoid, but these are very small numbers, so I think we really need to look at this more carefully.
Okay, very good. Nice discussion. Let's move on to the next case. So this is a 71-year-old who presented with acute shortness of breath and chest pain while she was on vacation. She initially thought it was a pneumonia and took a Z-Pak. She does have a history of breast cancer, currently NED. She also has a history of rheumatoid arthritis, currently on 10 milligrams of prednisone, as well as Plaquenil. Her labs are all within normal limits, except her blood gas shows a PO2 of 78. Her O2 sat is 85% on room air, and a CT scan of the chest was obtained. And you can see in the panel on the left, she has a massive pulmonary embolus in the left pulmonary artery. She also has a large pulmonary embolus in the right pulmonary artery. So bilateral pulmonary emboli. And if you go a little bit further down on the CT scan of the chest, you can see that her vena cava is occluded with what is likely tumor thrombus, and she has a locally advanced tumor involving her right kidney. And on the lung views, you can see that she has some pulmonary nodules that are small and at this point indeterminate. So she is started on Lovenox and returns home for further staging and imaging. So a CT scan of the abdomen and subsequently an MRI of the abdomen was obtained. She did have an MRI of the brain and bone scan, both of which were negative. So here's her CT scan of the abdomen. And again, you can see a locally advanced tumor involving the right kidney with a renal vein and IVC thrombus that looks like it extends up to at least the diaphragm, if not extending into the right atrium. She does not appear to have any retroperitoneal adenopathy at this point. And here's her MRI, again showing the locally advanced tumor involving the right kidney with a very extensive IVC thrombus extending up to at least the diaphragm. And you can see on the final cut that I'm going to show you that it actually extends up all the way into the right atrium. So, Dr. Beaslin, what would be your recommendation for this patient?
I would, she doesn't have anything that you really know about except the tumor thrombi going up. So I would talk to the thoracic surgeons about if they could help us operate her as soon as we have control over the timing with the embolus.
Okay, so a couple of questions about that. Is there any point in delaying because of the bilateral pulmonary emboli? Is there any danger in taking her to surgery because of her decreased oxygenation and diminished respiratory function?
That will probably be of a risk. So you have to discuss this with those who's dealing with those things every day. This is not very common at our hospital. So it will probably be a risk to do it very, very soon. But I think as soon as she's able, I think you can actually get a quite good oncological results by operating her as soon as possible. But of course, you have to take all the problems into consideration.
Okay, Dr. Lund, do you agree? Or how would you approach this patient? Patient like this in our outpatient clinic, we will of course tell her that it's a very serious condition. We'll put her on antigen prophylactic treatment right away. And then we have 2 places in Denmark taking care of these. So we do it in combined session with thoracic surgeons and vascular surgeons, and then of course urologists. So we are working a case like this together. So from my medical oncology colleagues and anyone feel free to chime in, is there any role here for neoadjuvant therapy, especially since this patient's respiratory function is compromised? Would anyone consider giving her neoadjuvant therapy to allow improvement in her respiratory function to make her a better surgical candidate? And if you would, what would you recommend?
Yes, absolutely. So, obviously anticoagulation, and then I would consider a TKI PD-1 combination to try to get the tumor under control, so to say, maybe even get some shrinkage neoadjuvant. We've done it for quite some patients. For some patients, we also have some data for neoadjuvant irradiation with SBRT of tumor thrombi that Dr. Hanan at our institution has generated that are quite interesting. Some patients who are actually unresectable with some good efficacy, and surgery can sometimes be done afterwards. So this would be a patient where we would consider neoadjuvant therapy potential for stereotactic radiation of the tumor thrombus and let the patient resolve first her impressive emboli.
Yeah, so we would have the same strategy as Hans. We would perform a biopsy of the primary tumor, and then we would discuss in the tumor board the opportunity to perform TKI-IO combination in a pseudo neoadjuvant, because we do know this patient is metastatic. We saw the lung nodules, and she may actually improve clinically from her pulmonary symptoms related to the pulmonary embolism, thanks to, or to some extent, thanks to the anticoagulation.
So I have a couple of questions for my surgical colleagues. Number one, is there any role here for preoperative embolization of the primary tumor? Does anyone do that at their institution? That's the first question. And the second question is, when and if you take this patient to surgery for the IVC thrombectomy, obviously the patient's going to need to go on cardiopulmonary bypass to take the tumor thrombus out of the heart. Would you also consider prodding your thoracic surgery colleagues to do a embolectomy?
Please repeat the first one again.
Would you consider preoperative embolization of the primary tumor prior to taking her to surgery, both to decrease blood loss, potentially cause regression of the IVC thrombus, and make surgery easier?
We have done that a couple of times, but we will have to have a closer look at the images to see how difficult it will be to get to the area. But I think you will get control over the renal artery quite well. And of course, we'll discuss it with for the second part. We will discuss it with doctors, the cardiothoracic surgeons, about what they feel about that, about doing the embolectomy. I think you will probably not do that at the same time. That's my feeling, but that's not having the images, all the images, and not having discussed it with them.
Does anyone else have any other comments about the issues that have been raised so far?
So Chris, usually we discuss embolization prior to surgery to the bone, or in a highly symptomatic patient in a more palliative setting with hematuria, for instance. But we would not discuss that prior to surgery to the primary or to the thrombus in this case.
Okay.
I think I would be guided by my surgical colleagues about operability here. If they were happy that they could operate up front, I'd probably be happy for the patient to proceed down that route. If there were concerns due to ongoing problems with breathlessness or desaturations, then potentially neoadjuvant TKI is what I would have access to in the UK. I think I would be worried that the response to the neoadjuvant therapy is unlikely to be so significant to significantly alter subsequent operative risks, because I think the clot is still going to be extensive.
Right, and I would say in our experience that neoadjuvant TKIs typically do not result in any major significant diminution in the IVC thrombus, both in its diameter or its height. But by the same token, the tumors don't typically progress, so there might be a way of buying some time to allow some improvement in her respiratory function before taking her to surgery. But in any event, we found that the patient was a surgical candidate. And so she was taken for a right radical nephrectomy with IVC thrombectomy and cardiopulmonary bypass. There was no attempt made to extract the pulmonary embolus. She remained hospitalized for 2 weeks due to pulmonary complications and also a recurrent right pleural effusion, although the cytology from that effusion was negative. Her pathology showed type 2 papillary renal cell carcinoma with negative margins, nuclear grade 3. She returned 6 weeks later with repeat staging. She still has shortness of breath and still has weakness. Before we move on to the next slide, I just wanted to tap on my surgical colleagues again and ask them, with regards to their thoracic surgery colleagues, do they typically do hypothermic circulatory arrest or just cardiopulmonary bypass to extract these tumor thrombi? What's been your experience?
At our two hospitals, they do a cardiac arrest normally.
Okay.
And then the other one I hear.
Okay.
Bypass.
Yeah, we do bypass. We do not do circulatory arrest. So moving on, she has an MRI of the brain and bone scan, both of which are negative. She still has anemia, but her labs are otherwise within normal limits. Her CT scan of the abdomen is negative except for postoperative change. And here we see her CT scan of the chest. You can see that the thrombus the pulmonary embolus has actually increased in size, indicating, at least to me, that this is in fact a tumor embolus, not a bland embolus. And you can see she's got larger and more pulmonary nodules in her chest. It's also shown here. So again, to summarize, this is a lady with type 2 papillary renal cell carcinoma, status post right radical nephrectomy with IVC thrombectomy and cardiopulmonary bypass. She still is a bit frail with a performance status of, I'd say, 1+ to 2, who has now progression in her thorax with bilateral pulmonary nodules and also the tumor embolus. Let's throw this one out to Dr. Negrier. How would you approach this patient? What would you recommend?
Well, she has a papillary tumor, so it's not so responsive to what we usually have in hands for the regular clear cell cancer. But anyway, we have some data, interesting data with cabozantinib first and maybe for some combination with IO. So if it's possible, I would propose IO and cabozantinib to that patient. Maybe not very urgently, since maybe she can recover a little bit for shortness and everything, because she has a risk of course, of complication like autoimmune pneumopathy, so it would be difficult. So probably I would wait a couple of weeks or some more time to start the treatments.
Dr. Hammers, what are your thoughts?
Yeah, so obviously papillary is less well defined what the optimal approach is. I agree with you. We don't have to start right away. I think the patient should nicely recover from surgery. Obviously, there's some discussion going on, which TKI, or shall we use TKI, PD-1 combinations in that particular patient. Obviously, the cabozantinib data that Dr. Pal has generated is very encouraging. So a higher efficacy clearly than sunitinib in the upfront space across different actually papillary subtypes. And personally, I would actually combine it with nivolumab. I would use a cabo-nivo approach in this particular case because we do know that papillary renal cell carcinomas do respond to PD-1 inhibition with single agent activity of around 20%.
Dr. Pickering, how would this case be treated in the UK?
So I agree with I agree with what's been said. The thing that's worrying me a little bit, however, is that she is still breathless and the tumor thrombus is propagating. So I think we may be able to wait a little time, but actually I'm not sure that we can wait very long on that basis because I'm worried about her respiratory function. I know we had objective readings of how that was when she first presented preoperatively. And actually I would be interested in repeating those measurements to see what is happening post-operatively at discharge and now to understand what the level of respiratory compromise is, because that might change my thoughts around timing of therapy. In terms of type of therapy, however, I agree that particularly on the back of Monty Powell's data about cabozantinib, I would ideally wish to use cabo-nivo. That's not available to me, but I would be wishing that it was on the basis that we've heard.
In the absence of that in the UK, what would you recommend for treatment?
Oh, sorry, what would I do? Okay. So I again revert to something I said before, that my options here would be ipi-nivo or axitinib with avelumab. They would be the only licensed approved available options available to us on the NHS. And so on that basis, I would be more likely to use IO-TKI. But actually, I am a bit concerned, and I am a bit concerned about the long-term benefit here. So actually, for me, it'd be quite a difficult decision, I'll be honest with you. I'd be more likely to go IO-TKI, however.
Okay, does anyone have any other comments about this case?
I think we have nothing to say that we can go for TKI plus IO here. I think I would go for cabo single agent after at least 4 to 6 weeks after surgery. Especially for the wound healing challenge we have with cabozantinib. And we need data that would randomize TKI versus TKI IO in those patients with papillary tumor. And this is what Sylvie is conducting.
Okay. Let's move on. So this next case is a 59-year-old white male who presents with a left varicocele. He also has had a chronic cough for the last 6 months, fatigue, occasional fevers, and night sweats. On physical exam, he has a a palpable mass in his left abdomen with a left varicocele. CT scan of the chest is negative. His labs are within normal limits with a hemoglobin of 13. And you can see he has a locally advanced tumor involving his left kidney. He undergoes a left radical nephrectomy with RPL&D. I don't imagine there would be any controversy about whether or not to do that, although I would be curious as to whether or not the surgeons would do it through an open approach or through a laparoscopic approach. His pathology revealed a T3A N0M0 Fuhrman's grade 2 clear cell renal cell carcinoma. So going back to the two surgeons on the panel, would you perform this laparoscopically or would you do it open? I can show you the film again.
We will do it open.
Yeah, okay.
Yeah, we will also do this case open.
Would you do a lymph node dissection?
If
Yes.
if there's no lymph node at the CT scan, we will not perform routinely a lymph node dissection. But if we during surgery can feel that there are with our hands that there are something, they are hard or something, maybe we'll take some of them for frozen section and then go back if we get a positive answer from the pathologists.
So you would do a frozen section on any suspicious lymph nodes?
Not routinely, but in a case like this where there is a huge tumor, we'll palpate, but normally we'll be guided by the CT scan.
Okay.
I think we would go into it with an open mind to see what to after check the CT scans out and check for lymph nodes underway, and also follow he had a varicocele, so you have to go quite low down to see if there is tumor thrombus going downwards. We've seen that a couple of times. So but do this with an open approach so that you have all the possibilities to do what we feel be right for the patient.
Okay, and so assuming that the patient comes back at 6 weeks and all the scans are negative, would anyone consider offering this patient any adjuvant therapy?
No.
No.
Also no.
Although they would be eligible potentially for adjuvant trial with an intermediate Leibovitz from what we've got so far.
Okay. So no to adjuvant therapy.
Could I ask a question here?
Yeah.
Who will advocate that using antithrombophylactic post-operative treatment, is it worthwhile, for instance, 2 weeks, 4 weeks, or what will you prefer? We will use, in this case, stockings and then 4 weeks antithrombotic treatment.
With what agent?
Low fraction.
Oh, like Lovenox, okay.
Yeah.
That's typically my practice as well. They're certainly post-operatively, they're put on prophylactic Lovenox, and usually we send them out of the hospital on it. We are trying a new approach through a clinical study where we're looking at the role of Eliquis as a potential prophylaxis after surgery that we can send patients out on, but the data is still out on whether or not that's equally effective to Lovenox, because one of the big problems is Lovenox is quite expensive. Especially if your insurance doesn't cover it. And also it requires obviously the patient having to inject them themselves or have someone inject them. So it can be quite a hassle post-operatively. So we'll see how this trial with Eliquis works out. Okay, so we're all in. Go ahead.
One more surgical question, Chris. What would be your template for the RPL&D in this case?
So in the absence of any lymphadenopathy present on the scan, I would just remove the ipsilateral nodes along the aorta. I typically would not necessarily go inter-aortic cable unless, again, there were some enlarged lymph nodes that were suspicious.
Good.
So the patient is followed with serial imaging. We do not offer adjuvant therapy. And the patient remains NED until 22 months after surgery. And again, I can barely see it myself, but you can see that there's a tiny little nodule in the left upper lobe of the left lung. And this was elected to follow initially because it was thought to be indeterminate. So the patient returns 6 months later or 28 months after surgery. There's no other obvious evidence of any metastatic disease. Clearly, you can see that the nodule in the left upper lobe of the lung has increased in size. So my question to the panel members, and I guess I'm going to start with Hans, what would you recommend for this patient?
This is a good risk patient, and the patient has all options on the table, ranging from local therapy, surgery, SBRT, all the way to systemic therapy, although quite frankly, in somebody, with just a single slowly enlarging lung nodule, no other noise, no other concern for metastatic disease, my personal preference is to actually just cut it out or radiate it.
Which one?
Isn't it just one lung nodule?
Yeah, no, there is one lung nodule. I'm asking which therapy. You mentioned SBRT versus
I send the patient.
Which is it?
So I send the patient to both, and then they can decide what they prefer.
Okay. So to my medical oncology colleagues, would anyone consider systemic therapy in this setting?
We would not. Our approach would be, this is, as Hans has said, a favorable risk patient. They have passed the trial of time in that they had the initial period of surveillance and no other sites have developed. So we would also be looking for a radical approach, a local therapy approach. And actually this would go, we would send the patient with that to our thoracic MDT colleagues and ask them to look at the imaging to see if they had any particular leaning themselves towards surgery or radiotherapy, but with the clear message that we, as the renal team, felt that that was the correct approach. The only other thing that would happen in our practice before, for example, surgery for a single site of metastatic disease is that the patient would have a whole body MRI to complete preoperative staging to make sure we were not, for example, missing any occult metastatic bone disease. But other than that, exactly as previously said, and no, we would not be offering systemic therapy at this time.
I agree with that. The only thing I would add is I think it's important how this patient is counselled, because I think it's unlikely this is curative, what we're doing at 2 years post-op, already having one metastatic nodule. I think it would be important the patient's aware that what we're doing is rendering them NED again so that we delay any subsequent intervention. But it is likely that this patient is going to recur again further down the line. But I still would be taking a local approach at this point.
Yeah, the number that I would quote the patient is a 20% cure rate, 80% chance for recurrence. So certainly somebody at that time you can consider adjuvant therapy if it is available at the time.
Go ahead.
I think we would send him in here at our hospital. We would send him to either radiotherapy or have a discussion about surgery. But we would like to have him locally free of disease, and then we would take him back to the urology department to be followed as with no evidence of disease, and then we would start over when we find something new, and then contact the oncology department. That's the way we do it, and that's probably the way it will function at our department. Instead of starting to send him around, we will try to keep in where we have those with no evidence of disease.
If I may ask Lisa a question, she mentioned whole body MRI, which to me is very intriguing. We are doing some work on that here at UT Southwestern as well. How well is that established and easy to get, so to say? Because I do think it's a fantastic imaging modality and fantastic screening tool, particularly for bone metastases. If you could comment on that.
Yes, so it's available in our institution. I think our practice was partly evolved from an observational prospective study, actually led by Martin Gore when he was alive over 10 years ago, and showing the whole body MRI is a great imaging modality for picking up small volume bone disease. We're fortunate that we work in collaboration with our imaging colleagues, and they've supported doing this. As in the absence of really robust data here, of course, we do have some data that we've generated, but we also have some experiences where we've been stung, being honest, where we have had people have surgeries for single site metastatic disease and then present with bone disease very shortly afterwards. And we have wondered whether, so both the study that our unit performed, led by Martin Gore some years ago, and some personal experiences have led to that practice. So now for us, and we've had that that's been part of our routine work for, I would say, for a few years now, if we're taking radical approach in the absence of metastatic disease, we do perform a whole body MRI first. And actually the pickup isn't particularly high. And so the testing that we've described, the trial of time, actually will, I think, filter the appropriate cases and mostly, but we do have a pickup rate where we change practice on the basis of doing so.
Chris, I actually have one comment and one question for Lisa. So the comment is that we would discuss a third approach with the thermoablative techniques. But as Lisa did, we would send usually the case to our lung colleague to discuss the best approach in this patient. And we would actually maybe even wait for a subsequent CT scan and not rush into the local treatment. I think to Lisa is the following. So if you identify one small bony lesion, thanks to your whole body MRI, would that change your therapeutic approach and having like two curative intent on the two sides?
Great question, Laurence. My answer is going to be a slight cop-out, but I think it does depend on where that lesion is and what's available for it. So if there isn't a second other radical, so if there's another radical approach available, and we're very keen on vertebrectomy, for example, in carefully selected patients, and I mean really carefully selected patients, if the other site is not amenable to a further radical approach, then yes, it would change it, because I personally do not see the benefit in removing a small, whether it's moving surgically or by SBRT or by thermoablation, a single small asymptomatic site of disease, knowing you are leaving another site without the same approach. So I think it either is all amenable or it's not amenable.
Chris, there is a question from the audience whether a FDG PET scan will be of any value.
That's a good question. What does the panel think? Let's ask Dr. Negrier. What do you think about FDG PET?
No, not at all, because FDG will be negative in this patient for two reasons. For the nodule is very small, so we know that the sensitivity of FDG PET is around 1 centimeter. And second, this is a very slow progressive disease as it was first, because he has a grade 2 tumor, histologic tumor, and that's why the tumor was so big before it was diagnosed without metastasis. It's a symptom of a very slowly progressive disease. So in low progressive disease, slow progressive disease, the PET scan is really usually negative. So it's not a good system to detect a small metastasis in these patients. And maybe in more aggressive tumor, sometimes you can find PET scan could be useful, but not in this situation.
Does anyone disagree with those comments? Would anyone get a PET scan in this patient?
No.
Okay. All right, let's move on. So the patient was referred to thoracic surgery who performed a left thoracotomy and metastasectomy. A total of 6 nodules were removed from the left lung, 2 of which contained metastatic renal cell carcinoma, clear cell type with negative margins. Patient's now recovered from his thoracic surgery. His repeat imaging is without evidence of disease. So how would you manage this patient? And I'll toss that one to Dr. Waddle.
So I would be just placing this patient back onto surveillance. I guess the difference now is they have proven metastatic disease, so it would be a 3-monthly follow-up for stage 4 disease, and probably that would be done by myself in the oncology environment rather than prior to the metastatic disease, where it would be 6-monthly scans and performed by the surgical team. The only caveat to that would be if I had a trial option, and some of the adjuvant trials did allow this sort of patient to be entered if they had metastatic disease and were rendered back to NED. But I wouldn't otherwise be offering any standard therapy at this point.
Would anybody on the panel offer this patient any form of systemic therapy after the surgery?
No, we have data from the TKI era, especially after metastasectomy. We're pending data in the immune checkpoint era. We don't have that yet. Okay, so the patient was observed and now returns
8 months after metastasectomy. And you can see that, unfortunately, as you all commented on earlier, the patient has additional pulmonary nodules, very small and indeterminate, but present. But initially, because they were so small and so indeterminate, decision was made to observe the patient. And so now the patient comes back 3 months later after metastasectomy, and you can see that the nodules have increased in size, clearly indicating that they do probably represent metastatic progression of the clear cell renal cell carcinoma. So my question, let's say to Laurence, what would your recommendation be for this patient? And now remember, this is now, let's see, let me do the math here. This is 39 months after nephrectomy.
Okay, so Hans highlighted the risk of recurrence that was explained to the patient. This is what is happening, but a slowly growing disease, as Sylvie stressed. So what we will be discussing in this patient will be TKI plus IO. There is no rush to start. So if the patient wants to start by going on holiday, we would allow him to go. There's no rush to start, and then we would start with axitinib pembrolizumab. This is what is available in France.
Does anyone disagree with that approach?
In my practice, I would offer him nivolumab, ipilimumab, based on that. Essentially, a third of patients, almost no matter what risk, has these extremely durable responses. Really, the only treatment or the best treatment in my book with curative potential. He's also a candidate. We still do it. High dose interleukin-2. He can have responses. He has good risk disease. He can walk into any therapy he wants. He can take as many vacations as he wants and get second opinions. But the idea would be to steer him towards treatments with curative potential.
So you would recommend Nivo-Ipi?
Yes.
Don't you think this patient the risk group is favorable, if I guess, since there is more than 1 year between metastasis and diagnosis of primitive tumor. So in European country, favorable group patients have no access to Ipi-Nivo because of the results of the Ipi-Nivo combination that were not so efficient in this group of patients. I don't know whether maybe in US you have access to this combination for this patient.
Hans, you want to comment on that?
Yeah, yes, we do. So it's on the NCCN guidelines as an option for patients. And quite frankly, if you look at the real life data, and even now with the follow-up, and there will be some more data coming out at ASCO with the 5-year follow-up, it's very clear that there is a good subset of patients who responds very nicely, that PSF curves look really what we want them to be. And so to me, there's really not much of a difference there. In the future, maybe we will have biomarkers, right, that tell us if there's any inflammatory component, et cetera. But quite frankly, that's what I would still offer him.
Dr. Pickering, what about in the UK?
So we're in the same position as Sylvie is in France. So given this is favorable risk, there were no sarcomatoid features, we wouldn't have access to Ipi-Nivo. I think the data are telling us that there are certainly a subset of patients with favorable risk renal cell carcinoma who are destined to get long-term benefit from Ipi-Nivo. And of course, that's highly tantalizing, and those are the patients we want to pick out. But in the UK, we do not have access we would not have access to this for this patient. So therefore, we would also be recommending upfront IO-TKI. This is a 59-year-old patient who, as far as I can gather, is otherwise extremely fit, has undoubted metastatic disease, undoubtedly is heading towards systemic therapy. Agree with everything else that he has time to make this decision, and that's about a decision when to start. But in our hands, it would have to be IO-TKI because that's what we have available. Of course, we have TKI alone, but I don't see the benefit in doing that. So it would be IO-TKI. May
I ask a question? So we just determined, right, this is a patient who doesn't need therapy right away, can take several vacations if he wants to. What is the need for the TKI in this particular combination? Why not PD-1 monotherapy, so to say, why not? Data's out there.
Hans, we don't have access to that either up front. So it's just would not be available to us. That's not a possibility. Our options are IO-TKI or TKI monotherapy. On that basis, I would prefer to offer IO-TKI. Of course, there would be other patients with favorable risk disease where you might make an argument for TKI alone, but not this guy. He's 59 years old and fit. I would be wanting to offer him the IO as well.
But you cannot write for axitinib and pembro, start the pembro and wait until the first few scans and then start the axitinib if it doesn't work.
I'm not sure this is the forum for describing the audit process within the UK for ensuring that we are adherent, but there is one, let me tell you that. The other thing I should say perhaps is that actually during COVID, we have been given some leeway around this. So during the pandemic, we have been permitted to start IO monotherapy. So there has been a period when, due to COVID, we could perhaps have done so, but it's been very, very limited. But usually our internal audit would not permit that.
So just as a final comment on this case, would anyone consider just sitting on their hands and watching?
That's what I was just about to add, Chris. Yeah, but I think the only other option would be just continue surveillance. I don't think this patient is at any great risk. It does seem unlikely with a fit 59-year-old that the patient would elect for that. I think that would be more popular in an older patient or a comorbid patient. But I think it would be very reasonable to just do 3 monthly scans. He's not going to come to any harm from the current sites of disease, and the treatment is likely to be effective whenever it's implemented.
I was going to say, just to throw it out there, is there any data at all in the literature to say that if he gets treated now with this amount of disease burden versus waiting, 6 months, a year, pick a number, is there any data to suggest his outcomes are going to be different?
No.
Well, of course, we have Brian Reedy's data, don't we, from the TKI era on surveillance, which was prospectively collected and showing that it did not have any adverse impact on outcome. And there were also patient PR, was a PRO, patient experience element to that as well. Anxiety had scoring. And so certainly with Brian's data, so prospectively collected in the TKI era, we had data that said with that, in that setting, there was no adverse outcome from waiting.
I would say with the advent of the IO component, we maybe do consider earlier treatment now than we might have historically done. I think for single agent TKI, it would be very clear that surveillance would be a good alternative. I think with IO, we have a feeling that it might be better to try and implement with smaller volume disease, but I don't think we have data to back that up. It's more, I think, a trend in what I think oncologists are how we're practicing, basically.
I agree with that sentiment.
Okay, time to move on. Okay, so this next patient is a 62-year-old white male who presents with gross hematuria. He's got some medical comorbidities. Physical exam is unremarkable, and I'll show you his CT in a minute, but basically it shows a locally advanced right renal mass as well as bilateral pulmonary nodules. So you can see a very large mass involving the right kidney. There does not appear to be any retroperitoneal lymphadenopathy. It looks like it's abutting, but not necessarily invading the liver. And the contralateral kidney is normal. You can see the CT scan of the chest where the patient has bilateral pulmonary nodules that are suspicious for metastatic disease. The patient has a hemoglobin of 9.8. He's got an elevated LDH. All other laboratory studies are within normal limits, and his bone scan and MRI of the brain are negative for evidence of metastatic disease. So locally advanced primary tumor in the right kidney, bilateral pulmonary metastases that appear to be small volume, anemia, LDH of 1,000, patients continuing to have intermittent gross hematuria. And my question to the panel is, what would be the most appropriate next steps in this patient's management? So I'm first going to toss it out to one of our surgeons, Dr. Beaslin. What would be your approach to this patient?
We would first have him at the multidisciplinary team conference, but I think that this patient would probably, I think it looked like he has metastasis, and I think we would do a biopsy, and I think we probably would start him on some kind of neoadjuvant treatment to see if we will get into, and then re-evaluate him later for eventual surgery. So I think that would be the way to go here.
So you would advocate upfront systemic therapy followed by possible delayed cytoreductive nephrectomy in the presence of a response?
Yes.
Okay, Dr. Lund, do you agree with that approach?
Yeah, Denmark is very near to Norway, so we will totally agree with it. We'll do it in the same way.
So let me just throw it out to the entire panel. Would anyone consider an upfront cytoreductive nephrectomy in this patient?
I think we probably would in Manchester, yeah. I think this patient's anemic and symptomatic from the primary, and that's clearly the main volume of disease. I think despite the disappointing results from Carmina, I think this sort of patient would still be in a group that I think would benefit from an upfront debulking nephrectomy. I think if there was any reluctance from the surgical perspective in terms of chances of that being a successful resection, then yeah, systemic therapy would be a reasonable alternative with a delayed nephrectomy. It's doing well, but I think probably our preference at the moment would still be to debulk first in this sort of patient. Okay,
Laurence, what about in France? What would they do?
So I think the reason why we're not moving toward surgery in this patient is especially the anemia and the high LDH. So obviously this patient has the large tumor volume within the primary. Nevertheless, we would perform biopsy, start systemic treatment, and more in our tumor board, we are discussing delayed cytoreductive nephrectomy in a patient who is responding to a systemic treatment. So we would biopsy and start systemic treatment and further discuss the surgery to the primary in case of response.
And what would the systemic treatment be?
So we have the two options open, TKI-IO, IO-IO. I would be keen on having an IO-IO shot in this patient.
Okay. So, and unfortunately,
just have a comment, Chris, if I'm allowed to do that, because it's very seldom that the surgeons have a possibility to enroll patients into a clinical trial. But Professor Donskov have just made a protocol for the Scandinavian countries where it's possible to enroll these patients, and then we'll enroll in Ipo-Nivo for 3 months, and if they after that we'll randomize them if they to either deferred nephrectomy or continue with Ipo-Nivo. So I think that could really answer this question whether when we should offer patients cytoreductive nephrectomy.
And that trial is currently ongoing?
Yeah, it's just started. In Denmark, we have enrolled the first patients, yes. But we are planning to make it in the whole Scandinavian, and I really do hope that we can succeed in this.
So this patient was taken for cytoreductive nephrectomy, and that decision was based primarily on the patient's symptomatic primary tumor. They were having a lot of gross hematuria. They were continually coming into the emergency room for intermittent clot retention. So we decided to do the cytoreductive surgery. It showed clear cell renal cell carcinoma. You can see Firmus grade 4, so a very high grade aggressive tumor. Patient returned 6 months later. I don't have the scans, but basically it showed modest progression of the pulmonary metastases. There's no evidence of any lymphadenopathy, both in the retroperitoneum as well as in the thorax. So again, my question now to the medical oncologist, and I guess we'll start with Dr. Negrier. What would be the next appropriate steps in the management of this patient?
Well, we have an indication of a systemic therapy. The question is, would the patient start at that point, or we can wait a little bit more because the result won't change if you start now or some weeks later. So it's not urgent, but we will have to start something. If there is no sarcomatoid component in the histology, in the primary kidney, then we have the choice between IO-IO or IO-TKI, depending on other history of the patients. But one of these two alternatives. And then we choose together with the patients what we will propose.
What would be your favored regimen. Let me put it that way.
I think I would propose Ipi-Nivo because, as it was previously said, there is a chance that we can cure some patient with this combination without no so long follow-up for the TKI-IO combination. So probably I would propose first the double immunotherapy.
So I guess, does anyone on the panel disagree with that approach or have a different approach?
I suppose the only thing I might say is that this patient has grade 4 disease. So I would be, unlike the previous case, I'm certainly going to suggest systemic therapy sooner rather than later for this patient. We probably do have a little bit of time, but I don't think we certainly don't have as long. So I'd be starting treatment sooner rather than later. And on the basis of this disease, the grade 4 and the biology that we've seen with the very high LDH, I would certainly be recommending Ipi-Nivo to this patient.
Laurence, would you let this guy go on holiday or do you want to start him on systemic therapy?
So there's no rush to start. I would have started this systemic treatment, but now that you have operated on him, I would not rush on systemic treatment, and then I would go for Nivo-Ipi.
Okay, any other comments? Okay, let's move on. So this is a 79-year-old white male who presents with gross hematuria. He has a past medical history significant for hypertension. You can see some minor surgeries. He's got some mild anemia, elevated SED rate, minimally elevated LDH. And you can see he has fairly extensive pulmonary disease with a large pleural-based nodule in the left lung, as well as nodules in the right. And you can see that there's a locally advanced tumor involving the left kidney with evidence of a renal vein thrombus extending just to the os of the vena cava. Here's another look. You can see large locally advanced tumor involving the left kidney with a renal vein thrombus extending to the os of the vena cava. I'm going to throw this to Dr. Hammers at UT Southwestern. What would be the approach in this patient?
In this patient, so it depends on, I mean, this patient seems to have more of a disease burden, but I would love to initiate systemic therapy. The question is, how bad is the hematuria? Potentially, we sometimes radiate these tumors just to stop the hematuria and continue with immunotherapy. But this is somebody, it looks like the mass is pretty large in the chest. I would just start on Nivo-Ipi and then go from there.
Presumably after a biopsy.
Yes, sorry, of course, biopsy.
Yeah. Does anyone disagree with that approach?
No, I think the burden of disease is different compared to the last case, but it would be definitely upfront systemic therapy. We might embolize in our institution for bleeding if there was ongoing problems, embolize the primary and start Ipi-Nivo. Yeah.
My only other additional comment is that disease at the back of the chest wall on the left is quite a large disease, and we've seen a cross-sectional image there. I'd want to make sure whether the extent of that and whether that was invading ribs or even towards the spine, because that sort of disease can be very nasty and symptomatic if it gets into spinal roots, and I'm also conscious of that. So I would even consider if there was any uncertainty MRI scan to evaluate that better, and whether any local therapy might be needed at that site. But I don't know whether that would be needed. I'd want to evaluate it to have a look at that.
Okay, well, again, this patient was really suffering from the gross hematuria. We did consider doing embolization, but ultimately we did not. And so at the time we had a randomized phase 2 pre-surgical trial where the patient was, there was nivolumab alone, Nivo plus Ipi, and Nivo plus bevacizumab. He was randomized to the Nivo plus bevacizumab arm and tolerated his 3 courses with little side effects. And this was, of course, after a biopsy that showed that this was clear cell renal cell carcinoma. And you can see that he had some minor change in his pulmonary disease with some regression, particularly that pleural-based MET in the left thorax. And you can see he's also had some minor response in his left kidney, although the renal vein thrombus appears to be basically stable at this point. So my question to the group is, and I guess I'll ask Dr. Waddle to comment first. Would you toe the line, continue systemic therapy? Would you consider surgery, or what would be your approach?
Yeah, I mean, presumably if he's within a clinical trial, then there's a sort of protocol guidance as to recommended way forward. But I think outside of a trial, I would be definitely carrying on systemic therapy. I think if he's responding at an early stage, then you would hope that he may well get a deeper response with ongoing treatment. You may end up doing a delayed debulk, but I suppose if he responds really well, you may even find that that's not necessary. If you've got a patient where all of the disease is shrinking very nicely, he may actually avoid surgery altogether.
Laurence, what are your thoughts?
Yeah, I would stick to systemic treatment. Chris, which arm was he randomized to? Sorry, say that again.
It was Nivo plus bevacizumab.
Okay, great. No, I would stick to systemic treatment.
Does anyone want to consider surgery at this point? So it would be a big no. Okay. Well, like Dr. Watt.
Sorry, there is a question from the audience.
Yeah.
Whether this case does the VTT and its risk of causing VTE indicate upfront cytonephrectomy?
So the question is whether people are concerned about the tumor thrombus and whether that could progress on systemic therapy. I mean, certainly that's a risk from my perspective, but I also agree with the comments that were made by the medical oncologist at the start of this case that the patient's burden of disease in the lung was particularly troubling. And my concern about taking him for upfront surgery is that he may have rapid progression of his thoracic disease and subsequently not be a candidate for systemic therapy postoperatively. Does everyone agree with those comments?
Yeah, and I have to say, generally, we're not that concerned about thromboembolic risks from tumor thrombus. They respond to systemic treatment or don't, but essentially they behave as a sort of disease site rather than being a high thromboembolic risk. So I don't think the tumor thrombus would sway my decision in either direction, really.
Okay.
Chris?
Well, as Dr. Yes, go ahead.
A question: Did the hematuria? How did you stop it? Did you do anything, or did it stop by the treatment?
It resolved itself on the treatment.
Yeah.
So, like Dr. Waddle pointed out, again, probably in the absence of a clinical trial, we probably would have continued systemic therapy. But the way the clinical trial was written was that after 3 courses, if the patient was thought to be a surgical candidate, they were taken for surgery. If not, then they were biopsied and continued on systemic therapy. And so we did take the patient for cytoreductive nephrectomy. You can see the pathology was T3AM1. And then the patient was placed on nivolumab postoperatively. So in the interest of time, which we are running out of, let's move on. So this patient is a 57-year-old African-American male who presented with a history of hepatitis C and a history of renal cysts. And because the patient does have this history of renal cysts, his doctor ordered a CT scan. He had a CT scan of the chest that showed indeterminate pulmonary nodules. And you can see his CT scan of the abdomen, which shows a normal left kidney. And then basically what looks to me at least like a large hydronephrotic right kidney with a solid mass emanating off the atrophied renal parenchyma. If everyone can see that so that we can move on. So the patient underwent a cystoscopy with retrograde pyelogram, which showed a UPJ obstruction, which accounts for the patient's atrophic right kidney. There was a mass extending into the collecting system, but we could not get the ureteroscope by the UPJ obstruction. However, we were able to get a catheter up into the renal pelvis, where we did washings, and those washings were negative for evidence of transitional cell carcinoma or any carcinoma for that matter. Patient also had voided urine cytologies, which were negative. So my question to Dr. Beesland is what now?
Now, you two have been discussing the possibility that this was a TCC, and I think that we should try to get closer to an answer whether this is a RCC or a TCC, and I think maybe we would do a biopsy, percutaneous biopsy.
So you'd recommend
percutaneous? You mentioned
that again?
You mentioned that the patient had lung nodules. Could you biopsy the lung nodules?
No, they're sub-centimeter.
Okay.
Indeterminate. So I hear one call for biopsy. Dr. Lund, what are your thoughts?
We will look very carefully, and then we'll take the arm on the back on the radiologist to see where this is. This a Bosniak 3 or 4. We know if it's Bosniak 4 that there is a high potential, 95% are malignant. And if the patient had symptoms, then we will perform a nephrectomy in this case.
Okay. So again, indeterminate pulmonary nodules, locally advanced tumor of some type involving the right kidney with a largely non-functional right kidney that's obstructed. Let's see. Dr. Pickering.
Does this patient has a history of sickle traits?
He does not. Good question, though. Thought being that this could be renal medullary carcinoma.
Yeah.
Although it would be unusual to present with localized disease, as you're well aware. Typically, they present with widely metastatic disease. So I can tell you that my approach to this patient was he had no other evidence of metastatic disease except for the indeterminate pulmonary nodules. And so my thought was that, I would take him for a nephrectomy and while he's on the table, have the pathologist examine the specimen and do a frozen section to tell me what it is. And my thought was that if this was a transitional cell carcinoma, that I would do a completion distal ureterectomy down to the bladder cuff. But in the absence of metastatic disease, I thought that was the patient's best option for treatment. He was completely asymptomatic. So we did take him for a right radical nephrectomy with RPL and D. And the pathology came back as T4N0MX collecting duct carcinoma with invasion into the overlying peritoneum. His margins were negative. So faced with this pathology, Dr. Waddle, what would you recommend to this patient?
Yeah, so again, I wouldn't be recommending any adjuvant therapy. I think the collecting duct carcinoma histology is obviously associated with a bad long-term outlook and high chance of relapse, but we don't really have data to support any intervention. Again, if I had a clinical trial that allowed collecting duct histologies to enter for adjuvant immunotherapy, I would consider that, but otherwise they follow up with a CT scan.
Would anyone on the panel? Yeah, go ahead.
I was wondering, when did you learn about that this was a collecting duct, post-operative or intraoperative when they did a frozen section? And if you had known this before, would you have done it differently?
That's a good question. I mean, and I would let the medical oncologist sort of speak to this, but basically, at least in our experience, there's not a lot of good systemic therapy for collecting duct. A lot of times they'll treat it with systemic chemotherapy as opposed to the therapies that we've been discussing today. Again, my thought process was in the absence of any systemic disease, that aggressive surgical resection was the best option. Had I gotten a biopsy at the prior to doing surgery, I would have at least let him talk to the medical oncologist. But hindsight's 20/20. I can tell you that I did discuss the case with our medical oncologists after the fact, and they said they probably would have recommended surgery anyway.
Could they actually give you the collecting duct carcinoma diagnosis on frozen sections?
No, they didn't. And you know this. The pathologist barely will call it cancer. Never mind the type of cancer. So they did not give that diagnosis. That was received after the fact.
Yeah, and certainly in our MDT, if this was exactly as you've described with the biopsy. If there was a surgical option, we would definitely favour that for exactly the reasons you've said, Chris, that we don't have effective enough systemic options for this patient. So if there's a question mark over the lungs and a potentially operative primary, I think we would go with benefit of the doubt for the patient and go with surgical resection.
Okay, in the interest of time, I'm going to move on and just say he was followed with surveillance. He was NED in follow-up for 5 years. He moved to Korea and got tired of flying back to the United States for checkup, so he decided he was going to come back one last time. The indeterminate pulmonary nodules have remained unchanged. And here is his CT scan of the abdomen. So this is 5 years post-op. You can see that he's got retroperitoneal adenopathy in the retrocaval position. So I'm going to ask Dr. Negrier, what would you recommend for this patient? Sylvie?
Sorry. I say this patient was very lucky, I think, to be operated, because I'm not sure everyone would have done so. So obviously has no further metastasis, at least until now. So I think I think it's important to enlarge the surveillance time and have a longer follow-up for this patient, because could be some metastasis in the future, maybe 10 years after the primary kidney. But there's no treatment to offer in this situation, I think.
So you wouldn't do a biopsy, you wouldn't offer surgery, you wouldn't offer systemic therapy, just continue to observe?
Well, I think it's difficult to biopsy and probably have a CT scan or MRI to control the images.
Dr. Albiges, do you agree with that approach?
So I agree with Sylvie that he's very lucky and fortunate to have had surgery from you. I think if we confirm that he has some relapse, meaning that we are able to monitor that there is a growth in those lymph nodes, the two options are either surgery or systemic treatment. But because of the time frame of the 5 year, we need some pathology. So we do need to perform a biopsy. So in case he has disease progression on those lymph nodes, I would find a way to have a biopsy performed by the radiologist. And then we would discuss either surgery or systemic treatment. And given the time frame, I know this is not common, but I think I would be happy to discuss surgery if that's feasible to render him NED.
And if you were going to give him systemic treatment, what would that systemic treatment be?
So we now have data suggesting that we need to have a doublet with a platinum-based combination. So that would be cisplatinum gemcitabine if his GFR allows this. We've had prospective data investigating the role of added bevacizumab, which unfortunately did not pan out that well. So I would be a doublet gemcitabine plus cisplatin.
Okay, and I guess my only comment to the comment about biopsy is that, you know, I mean, his scans were stone cold clean for the last 5 years, and then all of a sudden this mass shows up. And so my line of thinking was that there could be no question about what this is. I guess you could rule out lymphoma maybe, but from my perspective, this was the only site of disease. I did discuss the case with my medical oncology colleagues, and, you know, again, going back to what Dr. Waddle pointed out, that we don't really have a lot of good systemic options for collecting the carcinoma. We decided to take the patient to surgery. And so,
Chris, may I make a quick comment? Sorry. Sorry, Tom.
That's all right. Around PET, perhaps, Lisa? I don't know if that would be your comment.
No, you go, Tom.
But yeah, I mean, I think this is a case where we would use PET. I think PET could be helpful to confirm uptake in those abnormal nodes and confirm that there isn't disease elsewhere. I think unlike the clear cell RCC case that we discussed earlier, I think we would expect PET avidity for a collecting duct. So it might be helpful if you weren't able to biopsy before going into the operation, just to confirm.
Okay, that's
the comment I was going to make is that so I had a patient not dissimilar actually, but I didn't manage it exactly the same. I would say with that amount of with the time-free interval, I would certainly be asking you whether it was feasible to resect those lymph nodes. I was reasonably persuaded on the imaging, but I absolutely accept this could be lymphoma. We don't know that, and we know that when collecting duct relapses, it usually does so quickly. So it is unusual. The patient I had who was not dissimilar, we did actually have adjuvant chemotherapy, and we have to be absolutely clear, it's an evidence-free zone. No, we don't know that. It's no longer an evidence-free zone for upper tract urothelial cancer, of course, where we have the POUT study showing the benefit of adjuvant cisplatin-based adjuvant therapy in that setting. Our patient actually did, to my mind, undescribably well and was extremely lucky, and we've actually discharged him from follow-up 2 weeks ago, 11 years out of the nodal surgery. The nodal surgery was 1 year after the primary presentation in this case, so not 5 years, 1 year, but 1 year when he relapsed in those same lymph nodes, same distribution, they were resected, and so we discharged him last week, more than 10 years out.
And so based on this pathology, would anybody on the panel recommend any additional systemic therapy aside from the surgery?
No.
No.
I just have one more question, Chris. How did you go back and look at the former scans, and was there a time lapse because of this traveling back and forth that you didn't want to do, so that you sort of didn't get? Because I think it's strange that it comes so quickly. If it's every 6 months after 5 years, it's very strange.
We looked at the scans from 6 months before, and they were clean. So a very unusual case. And just to finish it up, and I want you guys to be brief because I want to try and squeeze in one more case. He comes back 4 months postoperatively, and now he's got supraclavicular adenopathy. So obviously the patient is now recurred systemically and probably needs systemic therapy. So going down the line, Laurence, I think you already told us what you would recommend. Hans, what would you recommend?
Yeah, it's the same. It's going to be cisplatin-based chemotherapy, but this is palliative in nature and unfortunately poor prognosis.
Dr. Negrier?
I agree. Propose chemotherapy until there is no specific clinical trial to propose. And probably if there is only a limited metastatic site, could envisage radiation or something on the lymph node if it's a unique site after chemotherapy. Because chemotherapy, you cannot prolong this treatment until 6 or 8 months. So you have to choose another way if the patient responds to this treatment.
Dr. Pickering?
I'd offer cisplatin gemcitabine, so cytotoxic chemotherapy. I think is the conventional approach. There are anecdotes of isolated responses, of course, to VEGF TKIs and to IO in the setting, but the conventional treatment is cisgem, and that is what I would offer.
Dr. Waddle, I assume you agree?
Yeah, the same. Yeah.
Okay. All right, so according to the clock I can barely see, it says that we have 7 minutes and 17 seconds left, so hopefully we can knock this case out. So this is a 43-year-old white male who presents with right flank pain and gross hematuria. He complains of fatigue and weight loss. He has no significant past medical or surgical history. He's got bilateral pulmonary nodules. He's anemic. He's got mildly elevated LDH, minimally elevated calcium. His white count is normal. And you can see the pulmonary nodules. And you can see the locally advanced tumor involving the right kidney. And so let me just throw this out first to Dr. Hammers. How would you recommend treatment for this patient?
Biopsy and then consider systemic therapy.
And that would be, if it came back clear cell, what would you recommend?
Nivo-Epi.
Nivo-Epi. Okay. Would anyone consider cytoreductive nephrectomy in this patient who has pain and gross hematuria?
Only if it was absolutely required to control the hematuria. I would be thinking that a lot of your patients have a lot of hematuria, and if he's one of the same and it's really heavy hematuria, then of course, but otherwise I would preferring biopsy, and if renal cell carcinoma is confirmed, Nivo-Epi.
Dr. Beaslin, what are your thoughts?
I think that the question here is if the oncologists decide that these lung mets sort of need treatment, then I think we should start with Ipi/Nivo and re-evaluate afterwards. I don't think that hematuria it has to be very gross to sort of spark off immediate cytoreductive nephrectomy. And he has other poor signs as well. So I think we could start him on systemic therapy.
Does anyone, just to throw it out to the entire panel, would anyone consider, aside from with the flank pain and gross hematuria in that setting, which is the setting that it's in, would anyone consider upfront cytoreductive surgery, or does everyone want to initiate systemic therapy?
What is the size of the tumor, Chris?
It's about 10 to 12 centimeters.
Okay.
I mean, I think he has some poor risk features with the calcium, so I think it's that would be driving this, that the long-term prognosis for this patient may be poor. So I think you would lose time potentially with your cytoreductive nephrectomy where they're not able to get onto systemic treatment.
Okay, and just in the interest of time, this patient was actually referred to me by the medical oncologist because of the patient's significant right flank pain and hematuria, and they were sort of pushing me to do the cytoreductive surgery, which I did. You can see the pathology there was T3A N0M1 clear cell renal cell carcinoma with, again, focal rhabdoid dedifferentiation. His CT scans of the abdomen and chest coming back 6 weeks post-op showed minimal progression of his pulmonary disease, no evidence of disease in the abdomen. So my question to the medical oncology group, and we'll start with Dr. Albige, what would you recommend for this patient?
So on the CT scan you showed us, Chris, I saw a large right lung nodules. Did he have other metastases in the lung?
He had bilateral pulmonary
metastases. Okay, sorry, okay. Some others. So given that he has this metastatic burden, and I don't have the labs, but I guess they didn't turn out to be normal, I would start systemic treatment with nivolumab plus ipilimumab.
Okay. Dr. Hammers?
Yeah, Nivo-Ipi. Didn't change.
Okay. Dr. Negre?
Yes, well, we have the choice between Nivo-Ipi and Pembrolizumab, and I think according to especially the age of the patient, who is rather young, I propose Ipi/Nivo because it's I think the only hope for cure to him.
Dr. Pickering?
Chris, just for a surgical point of view, how did you perform the surgery? Open or with node dissection?
I did it open.
Okay.
I did it open. Mm-hmm. Dr. Pickering?
So this is a young man with poor risk features and aggressive histology. And I think there are sometimes debate about which approach, but to my mind, there is no doubt that Nivo-Ipi would be the desired approach for this patient. It's not one of the areas of grey for me whatsoever. This is a patient to whom I would certainly recommend Nivo-Ipi, both on the basis of the poor risk features and the desire for long-term disease control.
And Dr. Waddle?
Yeah, I agree entirely.
Okay. So according to this clock that's ticking, we're down to 2 minutes, so we probably don't have time to do another case presentation. Are there any questions in the chat box that need to be addressed?
No, I have been looking at that box the whole time, so there's no question.
Does anyone have any final comments before we wrap up this session? And I guess my comment would be, I really want to thank you guys. I thought this was a really good discussion. I think we covered a lot of ground. Hopefully it solidified a lot of the points that have been made at this meeting and other presentations. I thank you all for being good sports. Hope I didn't put too much pressure on you, but just enough. Anyone have any final comments?
Thank you, Chris, for putting all of those cases together. Really, really good cases that Gordon's talking a lot. So thank you for that.
Yeah, thank you, Chris. Absolutely.
No, it's
Thank you.
Very nice. Thank you.
Okay.
Okay, so I think we'll wrap up the meeting right on time. Thanks to you all.
I wanted to thank Chris specifically because of his eye condition and the fact that he was still able to join us. You really bring something unique to these sessions, Chris, and I really want to thank also the rest of the colleagues for a fantastic discussion. It's been hugely educational for me, and I know our audience will share that as well. So I'd like to hand over to Frede now to give us closing.
Thank you.